True. Am I audible? Yes, fine. Yes. This point will not come there. Point will not come there. No, yes. It will not come there. First. Okay, fine. Good afternoon. Yeah, it's good afternoon. And Honorable Chairman already given me a hint that we are running behind the schedule. So, condense it. I will skip some of the things in the introductory part and highlight some of the R&D part which are taken care at Naipal Kavuti. In a nutshell form, what will be the future aspects, especially for the students? Is it okay? Am I audible? Fine. Yeah. The next one. Next slide. Yeah. Let me take you to the historical in a very few seconds. Status of medicinal plants in India, it's enormous. For example, if you see, we have got pillars in this, like right from Rig Veda, right from Atharvana Veda. That was, since inception of the Vedas onwards, we are using the medicinal plants by different ancient pillars of this Ayurveda. Dhanvantari, God of Ayurveda, Bharadwaj. These are the people who initiated and inculcated the importance of the Ayurveda into the minds of Indian population ages back. Otherwise, we will remove this. Hello. Yes. If you see this is Sushruta, we know Charaka Samhita, Susruta Samhita. You mean the second part of Samhita means composition of the documents made by the respective pillars. Charaka, he has whatever it has written. Subsequently, the documentation was done in various plants being used for various diseases. The composition, that means documentation, archive and documented is called Samhita in Sanskrit. So Charaka Samhita, they are mostly widely accepted the text even now. Okay. Now if you see again medicinal plants, the history is ancient key figures I wanted to tell you. This is not an introductory and known things, only for youngsters. That's why when I got an invitation from Dr. Soma Das, I thought what it is. What is Adamas University? When it says it is a student-based, highly pumped by the intellectual students, then this slide is made. For scientific talk, this is not required. You see the Anaximander, 6th century BC. Next, Pythagoras. We know the Pythagoras principles also we studied. This Pythagoras also 570 to 500 BC. Next one is Hippocrates. You can see even this one Hippocrates taking some plant crude extracts for various diseases. He himself showed. He himself tried on himself. That Aristotle, followed by this Apollodorus and Asclepius. These are all the people who has the beginners of these historic medicinal plants and all. So, what is the I'm facing like this. What I have to show you? Okay. see herbal medicine scenario in India, if you see, in the world itself there is a 12 mega biodiversity hotspots. Few are there in the northeastern parts, sub-Himalayan parts. In spite of having the biodiversity hotspots, identified species are very less. Unidentified species are yet to be recorded by all of you. Unfortunately, in India, taxonomy is totally vanished, I can say. Salute to the UGC, still they are maintaining taxonomy here and there, here and there. Taxonomy means when I was studying biological sciences, pick up the plant and see whether it is a monocot or dicot, first classification. Once a monocot is there means whether it is a lobed or unlobed. I mean you forgot all the fundamentals, frankly speaking. There is no taxonomy, no one is there to take the taxonomy as a subject. Some of the things. Can you identify any private university that is offering the taxonomy MSc? I am happy to met one girl just now. That is, she is MSc Botany and all. At least I am very happy, thanks to UGC keeping the core standalone subjects alive. But now taxonomies, no one knows about it. This is unfortunate. More than 45,000 plant species are recorded by Chopra et al. Chopra and his colleagues long back. It is documented in CSIR Wealth of India volumes. If anyone is interested in the net, you go to CSIR and see Wealth of India. Of course, they are available in soft copies also. 45,000 long back. Now they have been increased. Mutations are taken place, and then another species also come. It is your duty to identify the new species which may be having immense medicinal properties. Next, about 7,500 species of higher plants known for their medicinal value. 25,000 effective plant-based formulations. Whatever you do, the extraction, fraction, subfraction, the beauty will be given by the only pharmaceutics department who can make the formulation for that. You have given some kind of a active ingredient. You will say, sir, it is showing anti-arthritis, anti-cancer, something. The beauty should be given, sustainability should be given. Standing in the field environment should be given only by Sutics department. So this is the scenario. I have to be like a traffic inspector, left side, right side. Historical review of this medicinal plants, if you see, I already told you, this is a 4,500 species, folk medicine. Folk medicine means scientific authenticity is rather limited, emotional confidence is 100%. Even now in Shillong, Abdullah, he has identified one, what is that, tumor. That extract of the tumor is able to cure the skin cancer of a 7-year-old girl in Shillong. He has not come to the light of the market why QC, QA is not there. Quality control, quality assurance and certification by the scientific validation. That's why if anyone taking the chemistry as a QC, QA, you are the leaders. I am not getting any applications for the post of assistant, associate or professor in the quality control. That means analysis. So why I am telling, my talk is not only to give subjects, whatever topic is covered, whatever research is done in NIPER at Guwahati and Calcutta. It is not only that, some kind of a career guidance also I want to give you. If you see this particular slide, we have registered formulations of 3,000 and formulations from the plants 25,000, folk medicine 4,500 and Siddha, Ayush may S is there, that is Siddha, 1,300 species and Ayurveda 2,000 species, Unani 1,000 species and homeopathy 800 species. Though these are all there in a nutshell, in a single slide I have brought it for you. That is the property of India as far as the medicinal plants are concerned. When it comes to the 45,000 we told. Out of 45,000, I have given the classification. When it comes to the 15,000 to 18,000 of the flowering plants, out of that, 28 are already extinct. Yeah. In the history of medicinal plants, you cannot see 28 species out of 1500 species. That means we lost the property. You are excellent in working, poor in claiming. Let me tell you. We lost basmati, we lost turmeric, we lost the neem. Why? In Puri Jagannath, that wood is not even touched by any red ant or anything because of it is made out of neem. It is a Kaliyuga Kalpavruksha. Azadirachtin from the neem will nearly kill that more than 12 species which will the public health as well as agricultural pests. But again there is a problem. Pure azadirachtin cannot sustain beyond 35 degrees temperature in the field. Then whose role is important? Formulation role is important. Thermostable formulation we are looking. Whether it is an EC emulsible concentration, WDP water dispersible concentration, anything. We want a formulation that will be a solution. That is the thing. Only 7,000 to 7,500 species are being used. Out of 15,000, 50% are almost gone. So, again, out of flowering plants, 700 are the Ayurveda, 600 Siddha, 30 modern species. That means modern medicine we are taking from 30 species from there. This is not good. Ask anyone to just be there. When I say next, you please ask them. No, I cannot do practice. You put someone there. It's not good. You just put someone there. Okay, he will say next, you please put it. Okay? Let us not waste the time. That means what? This slide shows classification of the herbal medicine. Okay? I am telling you one more challenge to the students. If you identify any species which is not recorded so far, the species name you can keep your name. In Pondicherry, when I was in WHO, one Iyengar, Professor Iyengar, identified one Rhomboromalmis species, new species. Rhomboromalmis, everyone knows it is a soil fungi. It's excellent biological control against the diphtheria pest, biocontrol agent. But that species is new. What is the name? Rhomboromalmis Iyengari. So, this is a challenge for you. That is a property for your family. Yes, what you have done in your entire life, I have identified new species. Similar. Next. See, I will not tell repeatedly, please. Next means it should be. Okay, challenges associated. Okay, in spite of having immense wealth of herbal medicines, why still we are fighting with that, unable to get any kind of a active ingredient or active formulation? Because regulations, standard extracts, and quality. I told you the quality control. That institutions are not there. Even if you have quality, there is a regulation here, GMP, GLP. Good manufacturing practices, good laboratory practices. From there only the channel should go. Okay. Next, research on herbal products also inadequate. Very few institutes are working on the herbal medicines and their drug discovery. Very few. So that is also another unfortunate thing. Challenges in education training. Whatever I did, I should share with you. Otherwise, publishing a paper, getting a patent, no. Sharing is very important, and igniting this kind of challenge into your mind is very, very important. Next one. Yeah, what can be done now? You described a lot about the problems and all. But what is the future course? No, protection and preservation of the traditional knowledge. I am telling you, biopiracy. A person, especially I have 125 traditional healers in my hand at Naipar Gauhati. The common belief in their family, the man, grandfather, he only will treat the patient, he will never pass on that one to the next son, or he may relieve that information. That belief is there in 4 or 5 generations. After that, the scientific organizations went and knocked to their door and tell we are also a party, and did not build the confidence in their mind. But whereas we are successful, I will bring an agreement. You are the owner. I am only worker. If anything comes, you are there. I want logo of Naipur. Naipur, Calcutta logo should be there because we have done the work. Totally I cannot sacrifice. When I have done that one which you could not do it for the past 3 decades, when I come forward with an agreement of the legal agreement, he can sue me in the court. But somebody should let the cat and come forward to build the confidence in their mind that will be there. That is not happened so far in the traditional dealers. Next one. Yeah, overall approach what? Next. You see here, first of all, when you go to the field, if you want to work in the drug discovery program from the natural products, select the plant. Plant selection is the first step. You please note down. Out of plant selection, what will be the one? Either random plant selection. You go to the market and see which one. I will tell you what is the random selection by giving my personal example in my course of presentation. Random selection, I already told you, ethanopharmacological, that means it is already documented. You wanted to pick up from there whose secondary metabolites are not known for biological activity. Okay. Next, approach based traditional system. Go to any kind of a pharmacopoeia. From there it is already listed. Go there and pick up. 3 types are there. Second one is authentication. Who will authenticate? Taxonomist. Morphology set. Identification 2 types. Morphology identification, molecular identification. Morphology means taxonomic key. If any computer students are there, I want to talk something deviation from this topic. You join hands with computer scientists and talk to the expert system for developing the key for each species. We have developed nearly 16 species. Within 2 to 3 minutes, you can identify a plant species. Yes, no, if then rule based. It is called expert system in if then. See, now people are loosely using the word of AI. AI, artificial intelligence, is nothing new to us because we are like goats, when we are going, first goat will cry, then next also will cry, last also will cry. Why we are crying means, you ask last goat, why you are crying, means the first goat in the group is cried, sir, I am also following. That is not correct. This is the one, you see that molecular identification through this, what you call, DNA fingerprinting. First one is the morphology, second one is, we have done the expert system classification of the plants and animals. Within 3 minutes, you can identify. Expert system is a part of an artificial intelligence. That's what I want to tell you. For example, it will start with the 2-way classification. This group is there, by horizontally bifurcated. First group, boys and girls. If then rule. Okay, whether the boy or girl is there, yes. Next, out of the boy, whether any kind of a reservation, sports or non-sports candidate, non-sports, merit based. Then you take the merit based, how he is selected. Top 100, top 50, top 10. That means everywhere the classification is going with the 2-way classification. If then rule based, that is nothing but the expert system. How you are identifying a boy based on the expert system or girl? There are certain rules. That is why it is a rule-based expert system. In plants, the rules are nothing but the parameters. If you pick up the plant, it is a monocot or dicot. If it is a dicot, whether it is a leaf is there or not. If leaf is there, plain or lobed. These are all the things. 2-way classification. You can work with any computer scientist that is copyright on your name. Register under your name under your university. Who will do that job? Interdisciplinary, beauty of interdisciplinary, I am telling you. You talk to your MTech, BTech student is enough in computer science with a simple HTML language. That is what this expert system we are doing since ages together. Now we are talking artificial intelligence. That is a small part of the AI. Okay. Next plant you have selected, then extracted with a suitable solvent. Next pure compound. Then after that biological screening. You need not wait up to the pure compound. When the fraction is there, go for screening of the 22 bioassays are there. 22 bioassays are there. See that 10 bioassays whether they will be useful or not. Then if they are lead molecules, go to the next. These are all well known. Only for students I am talking. Next. Yeah, Naipur Gauti Center of Excellence. I want to tell you, there is a scheme called PRIP, promotion of research and innovation in pharma and medtech sector. The Gazette has come from the Government of India in 2013 to 2023 August with a budget of 700 crores, and every NIPER has got 100 crores under this scheme. Especially NIPER Calcutta has got flow chemistry and flow chemistry manufacturing. And first installment of 25 crores also released in the month of only last month. We are all in hurry to spend the money before 31st March, otherwise, and everything is PFMS, the money will go back. So similarly, what is the center of excellence in NIPER Guwahati? Phytopharmaceuticals and herbal drugs, because we are sitting on the gold mine of the biodiversity. This is one of the recognized biodiversity of the 12 biodiversity hotspots of the world. So what is the objective actually? To develop one kind of a character the phytopharmaceuticals is a very, very big terminology what I am using. But we are interested in the first herbal drug development, where regulations are very, very limited. We can see the market attack the disease very quickly. Otherwise, the phytopharmaceutical route is very long and steps are more. But to reach that level, start with the Ayush route of this one. First one is over, file at least a few INDs. Next, develop, promote the local farmers and traditional healers. I already told you, there is one Arunachal Pradesh traditional healer with polyherbal formulation. He brought that anti-malarial compound to us that is really effective against the Plasmodium falciparum. You know, malaria means not as one type malaria. People are thinking, kya ho gaya, malaria hai? No. Scientifically, malaria is classified into nearly 5 or 6. Rural malaria, urban malaria, forest malaria, migration malaria. What is the migration malaria? You know that. You people are free from the malaria in this zone. I came from Guwahati, brought that falciparum happily in my reservoir. I stayed here. The local mosquito will bite you and then simply bite another person because there is no parasite, it is not a vector. But as once Murthy comes with a full of parasitic load of the falciparum, it will pick up from the gametocytes from my blood cells, introduce into you. You will develop subsequent life cycle of the malaria, and it will go to significant ring stage, and sporozoite will be developed in the salivary glands of the mosquito. It will introduce into you. Within 72 hours, it will be passed. That means I migrated from Guwahati to here and then passed on this parasite to you. This is called migration malaria. Industrial malaria, because of industry, if you raise any kind of a water pools where the Anopheles stephensii, urban bacteria only will breed, then that is called industrial malaria. Rural means Anopheles cultivaceus, it will breed only in the rural places. So you have to attack that particular vector as well as a pathogen with your natural products. Attack the vector at larval level, attack the malaria parasite at in the human side. But unfortunately, I want to tell you one thing. People who are working falciparum research for past 24 years, they are not aware what is the life cycle of the malaria. People who are working with the DEC, diethyl carbamazine versus the microfilaria of nematode parasite, they don't know what is the incubation of the filariasis. I want to tell you one thing. Don't catch hold of one parasitic topic without knowing the biology. I want everyone should read the biology, even the top scientists also. This is a strong message. I asked a person who worked with the JBC, wonderful publications are there. What is the life cycle? What is the incubation period of malaria? Leaving the roots and flying in the sky. That education will never sustain. Okay? Now conduct the skill development programs, training programs. My lecture itself is a training program for you without getting honorarium. Okay? Even if you give, you won't think that is different issue. Training program, continue COE, continuing education, continuing CEP, continuing education program is a integral part of any higher education institution like this. Give continuous training, not only to students, even to the lecturers or faculty. There is a called program TLC, Teachers Learning Center at the Tejpur University, where my faculty underwent program in sequential way 3 times. Okay, training man and woman are the student till last breath. Remember. Next one. Yeah, I am telling this is called as a random selection, I told you. Now I am giving examples. This is a plant, I call it in my common language, morning walk plant. Morning walk plant. Why I am telling morning walk plant? When I was walking backside the Ames, Gauhati, I saw this plant very interesting. And then I asked the owner of the small garden, what is this plant? No, no, sir, we are taking some leaf and then we are using for पेट के लिए use करता हूँ. That means there is something gastroprotective agent is there in the plant. This is from the Amaranthacea. Normally in the market also, we in South India we will use this one for all the, which is a nutritious support plant, wonderful plant. So this is not herbaceous and it is used as a folk medicine. Later on I came to know there. And we have conducted LCMS with the QDOF and all. I will show you. See the 38.7% of the terpenoids. They are the active ingredients that I can classify as a gastroprotective agent. Liver fibrosis. Okay, you know more than 25 people are affected with liver fibrosis. T2D, type 2 diabetes plus non-alcoholic fatty liver diseases put together more than 30% cases in India. How horrible it is. Dry eye disease, 30%. That means all people are having some or other. Unfortunately, it is there in dry eye disease only after 60. Now 25-year-old boy and girl are getting. Of course, because of your observation, without food you can survive, without mobile you cannot survive. Okay? You classify, and in the night, today how many times I have browsed this one, how much I have exposed myself, out of that how much useful, how much useless. Genuinely you classify. It is useless not only for you wasting of your time, you are going to lose your retina very soon. Okay? This LCMS. Next one. What I wanted to tell you, this is the Amaranthus plant alternative. The name is Alternatia brasiliana. I can say it is a AB. I classify it. In the subsequent presentations I can say AB. This is the plant I can. Violet color, same Amaranthus is what we take as a food, green color. I picked up this one. I want to acknowledge my colleague from pharmacology, Dr. Vidyadhar Sahu. He is the man who did that work on this. This is showing excellent liver fibrosis. It is reducing. Okay, this is the publication from this. Hepatoprotective effect of AB may be attributed to the high content of terpenoids. 38.7%, really considerable percent. Next. Yeah, you see different stages of the liver morphology, how it is getting reduced in the control, how it is getting, in the healthy situation. In the normal. I am giving actually representation of the liver morphology in the different experimental group. A group in the sense, that's the morphology. B in the sense, sonography. Sonography pictures also have shown that whatever content is there in the control, it is different. Whatever it is there, 50 milligrams per kg body weight, 100 milligrams per kg body weight, 200 milligrams per kg body weight in the animal system. These are all the things. I don't want to go to the bar diagrams. If you want, you can see black one is controlled, subsequent one, they have come down the fibrosis because of this particular extent. Next. Yeah, this is about the histopathology of this one. Clearly it is showing how it is getting reduced. Okay? If anyone wants, I can share the presentation. No copyright protected slides are there. Next. So this is the liver fibrosis, especially when you see in this one A, this is the control one, treated with 200 and 400. They have come down like that. That means I can summarize, it is a dose dependent factors. Next. Same thing in all those things, which is inflammatory cytokines, how it is getting reduced. Next. Similarly, in the case of liver fibrosis, especially in all the pyridoxation markers in the liver, this is a biomarker, how it is getting regulated by this extract. That means science is not there in everywhere. Science means only keen observation. When I went to when I gone for the morning walk, I have seen this plant. I called it water. What is this? Normally peat. I thought we are all mostly interested in the food. No, I thought they will use it for the doll and then sambar. No, he is using as a medicine. That only brought me to this level. Okay, next. Next. Yeah, same thing in the different proteins and their enhancement and the reduction in this. Immunoglobulin images also we have shown, it is a Western blot details. Next, Western blot, sorry. Yeah, this MA, one liver fibrosis, it is showing very good. Let me see, arthritis. 29% of the, 25 to 45% of the Indian population is suffering with the arthritis. You know arthritis are two types, one is OA and another is RA. Rheumatic arthritis and osteoarthritis. This is excellent, excellently it is showing that arthritis problem. Why? I know something about up to lab level. Then people who are literally treating this arthritis in Gauhati Ayurvedic Medical College, they also came to know about these studies. Then there is we are doing some kind of a Ksheravasti. That means they will take the extract from us and then put it in the milk. In Ayurvedic mode, they will put it. A person who is fallen with the arthritis and confined to the bed, after 6 months they will make them to walk and all. He will not be runner like a marathon and all. At least he will be able to perform his duties. There it was used in a polyherbal formulation along with the known compounds. It is not standalone. I am telling you. So it is working very efficiently. What more you want? Now they want to go for the Ayush route and then they will claim the polyherbal with the milk is a Ksheravasti is the wonderful solution for the arthritis. Next. Yeah, these are all the some of the images of inflammatory markers and then cytokine levels in the, we are using in the in vitro first. The raw cells are the 264.7 cells in vitro. Once it shows, we go to in vivo. These are all the things and are even Western blot also showing significant improvement on the arthritis. I am telling osteoarthritis, this is a rheumatic arthritis. Next. Same thing about the induced arthritis. We have induced arthritis into the animal model. Then we tested. You can see that normal control is weight is same maintained, whereas that compound induced one, the body weight is increasing with less arthritis. The arthritis model of the animals also they are showing it is exactly matching with the in vitro studies. Next. Yeah, same thing, images of all those things. Next. This is also same, but only thing is now it has come to the DLR4. I think that Vairak faculty is here. In industry, when translation takes place, DRL1, DRL2, DRL3, DRL5, and when it reaches, it will go to market. So it has come up to the level of the TRL level almost up to the 3 or 4. So we wanted to give it to any industry. That is next. So this is at a glance in a same thing which has been published in Journal of Ethanol Pharmacology. Okay, next. Now let me tell about the loose one what we are using, especially for the past 2 years. I am getting bored about listening the AI and ML. Artificial intelligence, we are nothing new to this. We are working since 30 years, 40 years. But the name is different. Earlier also we worked in the classification mode. Okay, I already told the expert system. See, artificial intelligence models are based on 2 types. One is a classification, second one is a clustering. Classification, I told boys and girls and faculty and students, 2-way classification. Clusterings, I have got 100 students or 100 faculty. Then I have to make excellent faculty, average faculty, poor faculty. That means what is this? This is called clustering. How you have made clusters? Based on the parameters. What are the parameters? His teaching capacity, his evaluation of the same, his way of lecturing, his way of contribution, how he is spending beyond the office hours. These are all different parameters of a faculty. Based on the faculty parameters, you will put the cluster, make a group. That is called clustering mechanism. You can go and see SOM, self-organizing map. That is under that data mining. It is widely used in several sectors, banking, insurance and all. Unfortunately, very less in our biological sciences. Whoever does any kind of you have huge molecules. Is it really possible to see but molecule by molecule to see based on the functional molecules. In the language of genomics, functional genomics, non-functional, is it really possible to classify? It is possible to classify even billions of molecules, to cluster them only by self-organizing map. This is there for the past 30 years. Self-organizing map in medical application, SOM in pharmacological, you see very few papers will be there. That means opportunity. Don't worry about the age of algorithm. Application is novel. That is important. Okay? These are all under the classification of data mining is there since long. Now only somebody is running after AI, I will also run after. In some interviews I was there, some people wanted, what is your future problem? I want to apply AI technique. Do you know what is AI? When I ask you, you don't know. Because AI is the budget word, let me use that also. So, what we have done, and see, whatever we have developed, I am telling you in a simple, crisp manner in the medicinal chemistry department of NIPER Gauhati, anyone can use it. What we have developed now, anti-cancer drug database curation. This means more than 3,000 compounds library is there. You can ask any from the website, you can send a mail, online mail, you will get it. Development of the website for the anti-cancer activity prediction. This is very important. This is the beauty of the data mining and artificial intelligence. Based on the past data, projection can be given with a 60% accuracy enough. Don't go for the 100% prediction rate, you will not get it. Government of India is also accepting chemical accidents up to 60% forecasting rate is accuracy enough. This is thing we have done it, and then prediction of the outbreak of the disease with the 60% enough. If you get 7%, 10% pocket it. That means benefit. 80% prediction rate, 20% you are beneficial. So like that, prediction pathway, next natural products database curation and maintenance. Next drug development of the web tool for easy of the natural products bioactivity and drug metabolism prediction. I will come to that part. And maintaining of the HPC, high performance computing, that is supercomputer, is there in NIPER Gauhati. I will give the technical description of that one and its application in the subsequent slide. Wider sharing. The supercomputer is not belongs to me or my family. It is a national property. It should be used by every Indian. But provided that particular person should have an interest to get in touch with me and then convince me for what purpose. That is the one. Next. This is the supercomputing facility. The specialty is one master node, 5 CPU nodes and total 8 nodes. And you know what is the percentage of, what is the, for using AI and ML very extensively, megabytes per, gigabytes per, now what the season is teraflops. 300 teraflops mission, that is done, we are having. After installation of this, we are helping even the certain CSR labs even in Uttar Pradesh as well as Hyderabad. That means where you are located is not a question. Delhi persons cannot raise the column and Arunachal Pradesh down the column. It is not that where you are located. It is not your longitude and latitude of the area. It is your attitude and aptitude of the behavior. Okay? That is the one. Now we have done what are the things? We have been awarded even the advanced Center for the Computer Aided Drug Design, CAD, by National Supercomputing Mission. We got a project, we have already delivered it, we got huge copyrights on this, and then we are helping others. Within few seconds, identity calibrations can be done. This is a part of this one. Next contribution I will tell you. Next. This is a PRAP activity prediction. PRAP means polyadipose, that means polymerase. PRAP1, that they are used for the breast cancer treatment. Currently, resistant toxicity treatment is a limiting factor. It is a challenge. To overcome that, existing model give high false, that means low sensitivity. Specific sensitivity is very low now. Now this one will give maximum sensitivity. Why you are not submitting your samples to the 600 megahertz NMR? You are afraid of your compound. You will not give it to them because your high sensitivity, your purity will be questioned. That's why you will submit your sample to 400 nmr. Whereas this one will give the high sensitivity with more accurate prediction. You know, this particular next one. This is one more important PREP inhibitor prediction. This particular one is also, you give that input. Second one is output will come in few seconds. Next one, this is a drug, phase 2 drug metabolism के लिए we have one kind of a program. This SOS, you know what is SOS full form? It is a site of sulfonation. This project, this particular software was well evaluated by various IT people in India, bioinformatician, and it is inaugurated by, you know, the father of supercomputer in India, Vijay Bhatkar, CDAC founder director. Now that's why he was a Padma Vibhushan, supercomputing inventor, right from Param 8,000, 9,000, 10,000, Param Padma. We have been listed for top 500 supercomputers in the world at one point of time. So now Param, a bioengineer, we got it, and then this is the site of sulfonation was inaugurated by that gentleman in CDAC, Pune, on the occasion of an international conference on the bioinformatics. What more you want? Your small idea of a student, Shiva, I wanted to acknowledge Shiva here. He is my PhD second year scholar, and Bhakti, she has come out with the almost 3 or 4 web servers developed by one PhD student. And they will come out with that, and we will push them, of course not pushing, we will bulldoze them to develop this web server. Okay, that's why creativity will come from only root level like students. Then we will certainly help you. And it is a great application across the world, people will use it. Next. This is some statistics which I don't want to do it. If you give the mode type, accessibility, reactivity and hybrid and all, you will get all these kinds of beautiful details. You can publish in an excellent paper with a good impact factor. Next. And this is the steps taken place. This is published in a very good high impact factor journal. The name you can see, the first one is Shiva. I have taken him to Pune. He is the owner of the patent. And we are all only co-workers. That fellow was overjoyed and then of course shed tears on the dais. Next. How to use this SPS prediction also it is there. I don't want to go to the methodology. But it is simple steps, very simple steps. If you have the data, input data there, you will get it. Next. Same thing, next. And what are the, now my AI contribution of this one is over as far as medicinal chemistry is concerned. I am switching over to the another engineering part, which is an integral part of pharma. That's what I am telling. Interdisciplinary, that total engineering part. Naipar Kavati was received a project with a cost of 5 crores. The name of the center is National Center of Excellence for the Pharmaco-Engineering. Where is pharma? Where is engineering? Mechanical engineering people of IT, MTech, they are doing in the Naipar Kavati. Similarly, Naipar Calcutta can knock the doors of IIT Kharagpur, they can work it with us. How? I will tell you. Now, next bola nahi hai na tayar. Okay, medical device. Say we started, we came to know that medical devices has got, I already told you medical devices contribution of India is 1.6%. We need huge manpower. All of you, everyone should be entered into the medical devices, even though nothing can happen. Suspecting India 2023, we may go up to the 6% in the global market. You see, if you take medical devices with integration of your pharma or biotech, you are the king. Don't go for any kind of a job. You start up your culture. Unfortunately, no one is giving any time. Just now I met 1 or 2 students. Why you want to come for job? I am looking for a job, someone told. Why? Why you are looking for job? BIRAC is inviting you to be an incubator in my incubator. Come to Adama Universities. Come to any incubation of BIRAC. We are literally looking for active incubators. 1.4 lakhs startup companies are there in India. Whereas in Assam, not even 400 startups. That's why migrating everyone like a medical representative to go everywhere and then please start your own business rather than coming for a job. whatever you did PhD, please convert into your idea and then apply to the BIRAC and come to my place. My place means wherever BIRAC incubation centers are there. You want to be a Sutradhari or Patradhari? Decide yourself. Sutradhari means leader, Patradhari member of a team. Think yourself, ask your own soul, stand opposite to your mirror. Say Sutradhari or Patradhari. If your mirror says only Patradhari means you are only Patradhari in the total your life. Then biosensors and devices and bio-design and biofabrication, CAD facility, SolidWorks and MATLAB and code, all the facilities are there in our medical devices. When we started 4 years back, medical devices, 2 batches came out. After seeing the success, MTTF we have started, medical device testing facility. Next. Yeah, I will see my secretary started this medical device testing facility here, and then okay, next. This is our facility, training of the manpower, R&D, medical devices, testing and all. This is a calibration. Next. Yeah, we are doing electronic calibration also. See, when your Adamos Institute is located here, this is the primary duty to cater the needs of the Bengal people who come corner of the state, in principle, followed by to the local, regional, national, global. Okay, I wanted to address the problems of the local and the regional first. That's why I started MDTF. The moment I started, unless you have a stamp, no one will recognize you, though you are a merit. That's why legislation is very, very important. We got NABL accreditation in 6 months. Then government of Assam came to me and then asked, can you calibrate all the instruments? Certainly, MDTF. Based on my NABL calibration, AMTZ, Andhra Pradesh Medical Technology Zone, spread in the more than 190 acres. They came and joined hands. I am talking since my childhood, industry academia mate, industry academia mate. My grandson also will speak, but nothing will happen. What is the gap between industry and academia? You just go there and tell them. Everything is revolving around ego. Why should I go to him? Don't go. Sit in your place and retire and then take pension. Because you never did anything during your lifetime. Industry person come, are industry people, academia people only, they will only teach and simplistically the students. This kind of thing should be overcome by talking each other. Everything can be solved. That is why AMTZ, I call him as the chief guest of my foundation day. They came to know about my MDTF facility. They sent a proposal in 2 days. I replied in 10 seconds. I am happy to collaborate. These things are gone to the Chief Secretary Ravi Kota of Assam. We have become an integral part of the medical policy, medical devices policy of Assam. Because I don't have ego and the industry person don't have ego. Go there and stand before the CS. No, we are partners and we are getting business. I will be self-sufficient. How long government will supply how long they will supply money to these higher learning issues? At least let me have 30% of my source become self-resilience. This is the calibration. Next. We are doing the mechanical. Next. Biosensors. Next. This is a bio-design and fabrication. We are going to start with AMTZ. Not only manufacturing, even maintenance also. Can you expect any kind of a manufacturing and maintenance in the academic institute? It is not blowing my own trumpet about my Gauhati or Calcutta. Even if you think I don't mind, because trumpet is mine, anytime I can pick out and then blow it, that is a different issue. But what I am telling, commitment, concentration and dedication. Next one. And it is a glance of the last but not least. This slide is a 3D printing and 4D printing. Personalized medicine. I want all the pharmaceutics people to pay an attention. This is only the center in not only India, in Southeast Asia, to have the center of excellence in the pharmacoengineering. When you go to a doctor, he will give 5 tablets or 10 tablets. They will ask you to take 3 tablets per day. That is paracetamol. What is the guarantee? Paracetamol 500 mg required for you. You may require 600. You are underloaded. He may require 200. He is taking 500 mg. 300 is overloaded. This is called personalized medicine. Is coming to the soon for 30 years. This is only the subject of medicine. So we have developed this additive manufacturing both in 3D and 4D, and then smart biomaterials exclusively for pharmaceutical 4D printing we are using. Can you believe it? Naipur Gauti is working with AIIMS Delhi for artificial eye in 3D printed one. Why means that some kind of a phobia can be avoided. The person feel it is like a normal, and we are testing on the March of my collaborator is Bhavana at this what is it? That she is an eye specialist in AIIMS Gauhati. Of course, sorry, AIIMS Gauhati will do preliminary. We'll go to the Delhi finally. This is the thing. What is the country required tomorrow and day after tomorrow? This kind of small things, whatever it is coming, because your title of the conference is a recent advance. That's why I have done all those things. Sorry for exceeding my time, but it is worth exceeding. So need to pop these things into the young minds. Next one, this is my holy place, Naipur Gauhati. Thank you very much. Jai Hind, Namaskar.
Thank you very much, Dr. Murthy. But please, since we are running late, there will be very little. I'm sure that the excellent lecture, invoke many questions. But since we are running very late, there is another lecture before we go for lunch. So I'd ask only 2 questions. The rest of the question we can reserve, including mine one. I have also some question. Those will be reserved during the lunch time. So 2 questions, please.
Good afternoon, sir.
Yeah.
So my question was, what are the... Hello.
Please.
So my question was, what are the characterization of active ingredients and their standardization as per Ayush?
There are parameters right from the first level, second level, third level. Okay, preclinical studies also not so robust. Then clinical studies also phase 1, phase 2 also not like CDSCO and all. The number of steps are less. That's why the products are coming out. Ayush is really very, very helpful for the drug discovery. The number of things are very less. This is authenticated. Ayush is very, very much authenticated, especially in the case of Ayurveda or phytopharmacy. I cannot say phytopharmacy, but herbal drugs.
Thank you, sir.
Even the normal route, if you want to go for this one, 700 crores to more than 750 crores, and time will be, we don't know when it will come out. Yeah.
Well, if there is none, that leaves one observation to Professor Murthy. He spoke of more involvement of the pharmaceutics or pharmaceutical engineers to see to match with the recent advances that we are carrying on. Just I am sharing with Professor Murthy and with the audience too that the role of pharmacy education entirely depends on the PCI, Pharmacy Council of India, and most unfortunately, the role of pharmaceutical engineering has come down. It has been brought down. So, a person like Professor Murthy saying it, and who heads the NIPA, I think it will give a lot of weight to the regulatory bodies also to rethink and remodel the syllabus. Thank you very much.
Thank you very much. And only 2 days back, Professor Kanakaraj, head of the department mechanical, he came to my room and NIPER versus IIT Guwahati jointly starting a course on BTech 4 years course. Entrance through that ISER aptitude test, I think. ISER, they are having a separate test. ISER, they are having ISER aptitude test. 2025 admissions are open. 4 years BTech program in pharmaceutical engineering. IIT Guwahati, they came forward and NIPER Guwahati joint degree were started. I think we are the first NIPERs to have a joint program with an IIT. Of course, we are the guest faculty there, they are guest faculty here. But to have a joint program, their council should be accepted, my council should be accepted. So please pass on the message to your juniors who are all 12th pass. They can get 4 years wonderful course, 100% placement definitely. Thank you.
Thank you, Professor Murthy, for the insightful session. It is my privilege to introduce the chairperson for this session, Professor Dr. Rajot Ray, who is an esteemed academician and researcher, currently serving as an emeritus professor of Adams University, School of Health and Medical Sciences. He holds an MPharm degree from Jadavpur University and a PhD specialization in novel drug delivery system, sustained and controlled drug release and enzyme immobilization. Proceeding over this session, may I request Professor Dr. Bishwajit Basu, convener of this program, to kindly come up and felicitate Professor Dr. Rajot Ray for this ceremony. Thank you, sir. As a token of appreciation, we would like to present our esteemed dignitary with a special gift. Sir, I request you to please stay on stage. One that embodies the rich cultural heritage of our land. The gift has been meticulously handcrafted by talented village artisans whose skills and traditions have been passed down through generations. By choosing this, we wish to honor both your presence and the incredible craftsmanship of our rural community. We hope you will cherish this humble token of gratitude just as we cherish the wisdom you have shared with us today. Once again, thank you for being here with us. We look forward for future collaboration and more opportunities to learn from you. Sir, I request you to please come in front of the stage. With great respect and admiration, may I now request Professor U.S.N. Murthy to accept this token of appreciation from Professor Dr. Rajot Ray and Professor Dr. Bishwajit Basu. begin with the first scientific session on the topic Cancer Nanomedicine Development and Interdisciplinary Research Opportunities. On this note, may I now request our distinguished guest of honor, Professor Dr. Wong Ting Hui, Department of Pharmacy, Malaysia, and Chairperson for this session, Professor Dr. Shajol Kumar Jha, Principal, Bengal College of Pharmaceutical Technology, Dubrajpur, to kindly preside over the session. Sir, I request you to please come up on the stage.
Yeah, good afternoon everyone. Thank you for giving me this opportunity to chair this scientific session. And I am privileged to have the resource person, Professor Dr. Wong, who hold a position of lecturer and principal fellow at the Faculty of Pharmacy, University Technology, Mara, Malaysia. So I request Professor Wong to start the session. Thank you.
Thank you. So thank you, Chairperson. And I'm not sure it's afternoon now, right? So I've tried to make the slides simple and less work, more graphic, because I understood today there are a lot of students, and I hope that you will engage in the presentation, and we can always discuss during lunchtime or tomorrow lunchtime. Okay, thank you. first of all, I wish to thank the organizing committee, Prof. Sajid, Prof. Bose, and Prof. Somar for your kind invitation and arrangement for me to be here. So I've been in India for I think more than 18 years. So every year I will come at least once to a few times. So this afternoon, the topic of my presentation focuses on our recent data on cancer nanomedicine development, and hope that this presentation will elicit multi and interdisciplinary research later on between Malaysia and the India research community. Next. Right. Just a little bit about India-Malaysia relationship. Now, in the 1960 to 1970, there are 30,000 Malaysian students studied in Indian educational institutions. And today, 30% of medical practitioners in Malaysia have been educated in India. So, India is no alien to Malaysia. Next. Right? So this is my campus, University Technology Mara. We have over 20 campuses, and the campus that I work in is the largest of all. Okay? You can see from the helicopter view. Next. So our campus is very well equipped, just like NIPER. We have sufficient and have a lot of extensive facility and infrastructure for research and education. In addition, we also have hospitals and hotels and hostels to welcome students and staff from Adamas University to join us in Malaysia. Next. Right. Now, back to the lecture purpose. So precision medicine, I think, is no alien to everyone. So it actually encompasses 6 perspectives: personalized, predictive, preventive, participatory, psychocognitive, and public. Right? So the personalized perspective of precision medicine basically is a healthcare customization platform where the medical diagnosis, treatment, and products are tailored to the individual patients. So basically, the personalized perspective involve analysis of the patient health, and subsequently we customize the required therapy, right? So the pharmacist will then sort of prescribe and dispense the required drugs and the relevant dose. Next. So the currently proposed personalized perspective of cancer therapy basically is derived from the judicious choice of therapeutic that have molecular targets defined by omics analysis. So basically, the patients will be subjected to health screenings on the omics analysis. Once we know the molecular target, the pharmacist and the medical doctor will choose the right drugs and administer to the patients. But today, I wish to highlight to you the precision attributes of a precision medicine. They do not consider the choices of excipients and formulations, which is the major role and responsibility of the pharmacist, right? So I shall further explain in the subsequent slide later on. Next. So the delivery of personalized therapy, meaning that the right drug and doses, actually requires the pharmaceutical technologies interventions, where we formulate medicines so that one or more drugs can be dispensed in variable dose at the intended release kinetics to the intended site of actions. Next. So to achieve that, drug carrier or dosage form design is a very important research areas. And in order to meet the personalized therapy objective, the dosage form must be able to be mixed and matched to provide the required dose specific to the patients, and the dosage form must be able to deliver drugs with the desired release kinetic, either slow, prolonged, delayed, or sustained release. And dosage form must be able to carry one or more drugs in a single system, right? So a lot of patients are actually polypharmacies, especially for cancer patients. And the multi-drugs dosage form can possess same or different drug release kinetics, so depending on the pharmacological roles of the drugs. And the multi-drugs dosage form may engage different targeting strategies, right? So in oral medicines, within a single tablet or single capsules, you may have gastric targeting and colon targeting, right, in order to tackle the relevant diseases. And more importantly, the dosage form should provide 100% bioavailability under all administration circumstances. This is never achieved. And that's why pharmacists, pharmaceutical scientists, and pharmacologists, we are working hard to design dosage form that can provide 100% drug bioavailability. So this is a great challenge. So for the past 100 years, no one can achieve. So I hope Adamas University can look into this direction. So to achieve a perfect bioavailability, multi-particular system will be a very ideal drug delivery system, right? Whereby it can be mixed and matched to provide the intended drug delivery attributes. And the multi-particular system can be broadly classified as nano, micro, or millimeters. Next. Right. However, despite multi-particular systems is ideal to deliver drugs and to promote bioavailability, the bioavailability of drug still remains unsatisfactory until today. So there are two major improvements that have been initiated by the pharmaceutical scientists. First and foremost is through physical-chemical modulation of the drug delivery system by means of material sizes or formulation sizes. Second, for skin drug delivery, you'll notice that we commonly adopt active technology before applying the medicines. So the active technologies can be like iontophoresis, electroporations, microneedles, or even ultrasound technology to porify the skin before you apply the skin medicines. Next. So in our lab, with reference to cancer nanotherapeutics, we actually have taken various approaches and strategies in order to improve the drug delivery and the drug bioavailability, right? Now, taking from the perspective of synthesis, so commonly we use chitosan as the polysaccharide backbone, and from there we covalently conjugated targeting ligands such as folic acid and peptides, as well as polyethylene glycol that can shield the nanoparticle. Covalent conjugates allows reduced leaching of drugs, permeation enhancer, targeting ligands from the nanoparticulate system, and thus can enhance their performance in vivo. Next, right? So having synthesized the covalently grafted materials, of course it needs to be subjected to processing and manufacturing in order to transform the materials into nanoparticles. So in our laboratory, we have actually built our own brand of nano spray dryers in order to convert the nanomaterial into nanoparticles. So these solid nanoparticles being small, commonly less than 400 nanometer in size. So this allowed them to interact with the cancer cells, allow them to permeate to a greater extent into the intracellular compartment of the cancer cells. Next, right? We are very keen to work on several cancers, and one of them is the colon cancer. Now, having designed a functional nanomaterial and able to convert them into nanoparticulate system, injections of nanomedicine alone will not provide much therapeutic benefits. This is because nanoparticle is very small, so it has a large specific surface area. The drugs tend to leach. The permeation enhancer or the targeting ligand that is grafted tends to leach from the nanoparticulate systems within the upper part of the gastrointestinal tract. So premature drug release, poor drug targeting, drug instability commonly occur with nanomedicines injection by oral routes. So in our laboratory, in order to overcome that, we have a number of strategies. Now, first of all, we synthesize nanoparticle, carry cancer therapeutics through covalently conjugated the drugs and other functional excipients onto the chitosans. We actually coacervate the chitosan derivative with the pectin into nanoparticles. The nanoparticles will then be mixed with the microparticles. right? So this blending of nanoparticle with the microparticle about 3 to 4 micron in size result in formation of soft agglomerates. So the agglomerates are soft, right? And subsequently we fill the agglomerates into the capsule and we blend it with alginate powder. Alternatively, we can also blend it with a mixture of pectin and methyl cellulose. So what do these excipients do within the capsules? So alginate basically is a polycarboxylic hydrophilic polymers. So upon ingestions of the capsules, so you realize that the biological fluid will wet the alginate. The alginates will turn very adhesive and sticky. So it will bound the soft agglomerates together into a yellowish plaque, right? So upon transit of the plaque from the gastric to the small intestinal regions, alginate being polycarboxylic acid, it will be ionized and dissolved. So the dissolutions and loss of the alginates will release the soft agglomerates. And the migration and travel of the soft agglomerate into the colon under peristalsis or microbial enzyme actions, it will then release the nanoparticles. And the nanoparticle, having targeting ligand attached to it, it will try to locate the colon cancer cell, bind to it, being endocytosed, and exert the cytotoxic effect. So the entire system has been proven, so it's quite, how should I say, performed rather satisfactorily in vivo as well as in vitro. Next. Now we also have another system which is actually a tablet system, but it's known as the DOME matrix, D-O-M-E, right? So what we can do is, having synthesized the solid nanoparticles, we can actually embed the nanoparticles in the different modules of the DOME matrix. For example, the blue modules and the yellow modules. For colon cancers, we can design the modules so that the modules upon assembling, it is dense in the core without any hollow center cavities. So this type of dense modules will then be transited from the gastric to the intestinals, followed by the colons, and release the nanoparticle in the colons to treat the colon cancer. Next. Right. This is just another slide showing a more complex assembly of the DOME modules into the DOME matrix. So you can see here I have 3 modules assembled into one matrix. So the drugs that I wish to be released in the gastric regions, we put it at the external end, whereas the drugs that needs to be released in the colon, we actually place it in the center of the entire matrix, so to reduce the propensity of drug loss in the upper part of the gut. Next. Right. Now, coating is not the only solutions to promote sustained release or delay release. Now, we can also design our particle system so that the drug is released in the colon without any help from the coating. Now to do that in our early investigations, I think this is done with Prof. Bose, right? We use alginate as the matrix materials, right? And we need to select the right calcium salt in order for them to be able to delay the drug release and only have the drug release in the colon. Now calcium carbonates, it will release the calcium to cross-link the alginates, so in order to densify the structure and prevent early drug loss. Unfortunately, calcium carbonate, now in the gastric region, in contact with the gastric acid, it will release carbon dioxide, and the entire particle will be rather porous and prone to premature drug release. Likewise, in our experiments, we use calcium acetate to cross-link the alginate into the dense matrix. It doesn't really work, although calcium acetate is highly water-soluble. And it is exactly why, being highly water-soluble, this calcium acetate can easily and rapidly dissolve, and it provides turbulent forces onto the alginate particles and result in the alginate particles dispersions and disintegration. Hence, there is a premature drugs or nanoparticles drug release in the upper part of the gut. Now, to succeed coatless particle system for colon drug delivery, now we should select calcium phosphate. calcium phosphate is not as hydrophobic as calcium carbonate, but it's not as hydrophilic as calcium acetate. So it will release the drug, it will release the calcium gradually within the alginate particles, and the entire alginate particles matrix will be cross-linked as it moves from the upper part to the lower part of the gut. And in that system, we can actually embed ethyl cellulose to help the calcium phosphates to sustain or prevent the early drug release. So the combination of ethyl cellulose, calcium phosphate, and alginates has been found to be an ideal system for us to deliver therapeutics to the lower part of the intestinal regions without the help of any external coating. Next. Right. Now, here in an experiment on intestinal targeting, right? Instead of delivering the drugs to colon, we wish to deliver the drugs to the ileum, the small intestinal. So it's equally challenging. And our first experiment, we actually blend the alginate, stearic acid, and the intended drugs and process them into the nanoparticles. As usual, nanoparticle experience very fast release in the gastric region and is not suitable. Hence, we blend with polyethylene glycol 10,000s and we compact it into a mini tablet. And the mini tablet we insert into the capsule, and you can see that the polyethylene glycol, being a very viscous polymer and high in molecular weight, they can actually prevent early drug release in the gastric region. And the drugs will only release in the small intestinal regions as a result of stearic acid acting as the wicking agents that beat the alginates as well as the drugs apart, so allowing the drugs to release in the intestinal regions to treat the local diseases. So we have double proof by preparing nanoparticle that is made from alginate only. It doesn't work. Without stearic acid, the intestinal drugs will not be released. Now likewise, if we covalently conjugated stearic acid to the alginates, intestinal drug delivery will not occur. So the stearic acid as the wicking agents, it needs to be there and it needs to be freely available within the alginate nanomatrix in order to break them down to release the drug in the ileum region. Next. And in the case of pulmonary drug delivery, it actually faces a similar fate as oral drug delivery. Now, in addition to that, nanoparticle being light and small, although it can be inhaled, but the issue is it will be exhaled. So as a result, generally nanoparticle experience very poor inhalations capacity, right? To overcome that, a researcher has been provided microparticles of nanoparticle between 2 to 5 micron in size, either through agglomerations, composite formations, or they embed the nanoparticle into the saccharide microparticles of 2 to 5 micron in size. But the process of agglomerations, composite formation, or microparticulations involve perhaps aqueous, medium, and some binder, and that result in poor redispersibility of the nanoparticles in the lung. So as a result, there will be inadequate drug reaching the lung cancer site to treat the lung cancer diseases. And to overcome that, next slide. In our lab, we actually have thought of a very simple idea. On one hand, the nanoparticle can be easily redispersible. On the other hand, the nanoparticle can flow into the lower part of the lung to treat the lung cancer cells easily. Right? So from this slide, you can see that nanoparticles by themselves are rather aggregative. Likewise, we have actually prepared lactose microparticles of about 3 to 4 micron in size. Right? These lactose particles, they are also very aggregative and cohesive. So what we have done is very simple. We blend the nanoparticles of drugs with the lactose microparticle at a specific ratio. So the nanoparticles will reside on the surfaces of the lactose microparticles. So just by looking at this schematic presentation, I believe you can imagine that as a lubricant, they also mutually reduce the cohesiveness of the lactose microparticles. So overall, a very flowable and inhalable powder is produced to deliver the drugs to the lower part of the lung for the treatment of lung. Heard of liquid nanoemulsions, but liquid dosage form has a lot of disadvantage, such as poor microbiological stability, poor drug physicochemical stability. So to enable us to produce solid nanoemulsions from the liquid nanoemulsions, you can blend the lactose particles with the nanoemulsions. But this simple blending will result in depositions of the nanoemulsions extensively on the surfaces of the lactose particles. And the nanoemulsions that we develop contain chitosan as the permeation enhancer and targeting ligands. So on that note, there will be excessive inter-lactose particle aggregations that result in formation of very large particle, not suitable for pulmonary inhalations. Is everybody alright? Okay. So to overcome that, we did a very simple act. So we blend the lactose particles with magnesium stearate. We allow the magnesium stearate to deposit on the surfaces of the lactose particle. Following that, we add the liquid nanoemulsion. So because of the presence of the magnesium stearate, the liquid nanoemulsion that contains chitosan will bind to the lactose particle, but not excessively. So as a result, smaller aggregates are formed, and upon spray drying, the microparticle that was produced are much smaller, lower than 5 micron, which is suitable for pulmonary inhalations. So the take-home message is we need to produce microparticles that is smaller than 5 micron, or if better, smaller than 3 micron, to enable an efficient pulmonary inhalation. Next. Now, skin delivery is the greatest challenge of all. Now, if you look at the top layer of the epidermis, which is known as the stratum corneum, it is the primary barriers to the drugs or the nanoparticle penetrations. So, the stratum corneum is constituted of keratin-rich corneocyte. It's embedded within the pink color lipid lamellars. Now, if you look microscopically, the lipid lamellars actually consist of lipid bilayers alternating with the aqueous pore. Now, if we would like to deliver nanoparticulate drugs, there are two routes, either intercellular or transcellular. And both routes of penetrations are rather challenging. First, it needs to encounter stratum corneum as the absorption barrier. For intercellular routes, you can imagine the pathway are very tortuous, the full of twists and turns. Next, so to overcome that, I think for the past 20-30 years, so scientists have invented microneedles, iontophoresis, electroporation, ultrasound, sonophoresis, photomechanical wave, and pressurized gas. But all these techniques, although workable, it does bring a lot of side effects like electrical shock, edema, burn, bleeding, and it could be environmental unfriendly like microneedle where you have a lot of disposable. Next. So in our labs, instead of following what the previous researcher have done, we try to brainstorm ourselves. Are there new innovations that can be developed by Malaysia scientists? So we do know that every one of us use microwave to cook the chicken, right? And the chicken, basically, you have lipids, you have proteins, and you realize that microwave could soften the meat. So with that so-called idea in mind, we then innovate microwave as the permeation enhancer for skin drug delivery. So we have carried out a lot of experiments, but here I'm presenting you the schematic diagram. So what the microwave will do is, upon treating from the direction of stratum corneum, the microwave will actually condense the keratin in the corneocyte, changing them from alpha helix to beta sheets conformations. So because your keratin condensed, Hence, the corneal site is also shrinking in size. And concurrently, microwave can also soften the lipidic material in the intercellular pathway. So the summative effect is you can see the aqueous pore is turning larger in the skin and allowing more nanomedicines to penetrate into the skin. Yeah, I do notice that. I've been here for 20 years. I do notice that usually speakers speak. We also have another conversation down there. Actually, when I come to India, it's not just meant for research or manpower training. So we also hope, I just spoken to Prof. Bose, we also hope to do some community work. Actually, one of the plan for us, I mean, as a non-Indian citizens, is to educate the students so that you are in line with the global scenario, right? All of you can speak English, but I think that's not enough. I think perhaps we need to provide you more exposures so that you are in line with the global audience, and that will help you when you go overseas for attachment. You can gel in faster, and after learning from the overseas experience, hope that you can come back and contribute to the India development. All right? So next slide. So this is just some of the Fourier transform infrared imagings. So using the right microwave for the right durations, so you can see the skin allow more nanoparticles penetrate from the epidermis into the dermis regions as marked by the red color domain. Next. And microwave versus the nanoparticle, chitosan nanoparticle in this case, it actually helps to fluidize and mobilize the lipid components at a different region. So the microwave tends to fluidize the ceramide 2 region, whereas chitosan nanoparticle, which is also a permeation enhancer itself, it tends to fluidize the palmitic acid and the keratin region. Next. Now, apart from skin deliveries into the epidermis and dermis, I think we also have a series of projects where we intend to deliver the drugs, the nanotherapeutic, from the skin into the systemic circulation. So to do that, it's very important to tag the nanomedicines with a targeting ligands. And in these small experiments, we actually have found out that a content of about 20% of targeting ligand is needed for each nanoparticles, so that they can attach firmly to the cancer cell and penetrates effectively via endocytosis. Next. Right? So nanomedicines, no alien to everyone. So basically it's a particle less than 1 micron and commonly between 200 to 400 nanometers. And it can be prepared from polysaccharides, proteins and other materials. And it can be decorated with a functional moiety such as polyethylene glycol, targeting ligands, and others. Next. Next. Yeah. So basically, cancers can be classified according to the organs. And what I wish to highlight to you is that each cancer actually expresses more than one cancer receptor. And pharmaceutically, we do have various targeting ligands that can be used to decorate the nanomedicines in order to be able to deliver the drugs to the specific cancer site. Next. Right. So you may wonder, throughout these 40 to 50 years, pharmaceutical scientists has developed very good targeting strategy, whether passive or active targeting, to deliver the cancer drugs specifically to the cancer cell. But why is that the clinical translation level is so low? So herein I just want to highlight one possible reason. Now you could see that upon administering nanomedicines by oral, pulmonary or skin route, now in the bloodstream, the nanoparticle needs to be negatively charged and hydrophilic in nature, so that the nanoparticle will not be removed and digested by the reticuloendothelial system, and also to avoid protein corona formations on the nanoparticles that may hinder their transport to the cancer cells, right? Now, even that the nanoparticles succeed in surviving in the bloodstream, penetrate through the endothelial cells and to the cancer cell. Now, upon meeting the cancer mucus layer, your nanoparticle has to be amphiphilic or hydrophilic. It's preferably not negatively charged. It must be neutral or near neutral with no net charge, so that it can transport across the mucus to go to the cancer cell surfaces. So at the cancer cell surfaces, in order for the nanoparticle to penetrate into the cytoplasm of the cancer cell, it has to be positively charged, hydrophobic and amphiphilic. So I hope that this slide is very important, so you can see that your nanoparticle needs to be a transformer, changing physical-chemical characteristic as it moves from the routes of administrations into the bloodstream to the extracellular matrix of the cancer environments as well as the cancer cell, right? So scientists has actually prepared nanoparticle with different layers of chemicals. So the nanoparticles, depending on where they are, they can actually strip themselves and exposing a new physical chemical property to allow them to survive and perform their intended tasks, right? So this has been done rather successfully, but again, the clinical translations of nanomedicines in cancer is still relatively low. Next. So why is that so? Even though we have invented or innovated different types of targeting ligands using different types of formulations, why is that the clinical application and realization is still not satisfactory? Next. So to answer that, instead of working in the lab, we begin to do reading, study about the medical and pharmaceuticals, journals and IP materials. So we realized that expression or overexpression of the cancer receptor actually depending on the cancer type, age, gender, race, geographical origin, living habit, environment, drugs, perhaps even food and infections, right? The Indian and the Malaysian Indian having the same cancer type, for example, colon cancer, but they may express preferentially a different types of the cancer receptor. Next. So if we design our nanomedicines for the Indian patient using the wrong targeting ligands, the nanoparticles will not be able to endocytose into the cytoplasm compartment of the cancer cell. So there will be a loss of cytotoxic effect, right? Hence the cancer cannot be healed by the therapeutic. Next. Likewise, we know that nanomedicines is not just drugs. You do have excipients such as matrix carrier, mucoadhesive, penetration enhancer, drug stabilizer, and particle steal. And different nations or even different races, they may have a different level of metabolizing enzyme. So assuming the Indian has a very high metabolizing enzyme, so you may digest the nanomedicines before the nanomedicines can reach the target site, right? Hence, designing nanomedicine, in my opinion, should consider the excipient and formulations choices instead of just look at the therapeutic choices. Next. And the entire games of designing nanomedicines becoming even more complex, as we know that excipient today is no more an inactive additive, but it could have a therapeutical effect, such as chitosan and oligochitosan. And this is the current work that is undergoing in our laboratory, where we look at the molecular biology's profilings of the oligomer polymers, as well as the nanoparticulate system derived from them. Next. So whatever I highlighted just now in cancer can also be applied in the diabetes. So for those who are interested in oral insulin delivery, perhaps you can join us in Malaysia. Next. So lastly, we should thank again the organizing committee, my ministry, university, postgraduate, collaborator from different countries, supporting staff, as well as my university manager and family and supplier and manufacturers. Okay, thanks.
Now, if I summarize the session, this mainly the presentation highlights the recent nano drug delivery innovations for skin, pulmonary and the oral applications. As we know, the bioavailability is always a major challenge for any pharmaceutical scientist, and that's why we try to go for a reduction in the globule size, or we go for multi-particular drug delivery system. That's why nanoparticle in different forms, it may be nanoemulsion or other forms, it is very popular nowadays. So thank you so much for your presentation. And the session is now open for discussion, but due to scarcity of time, I can request the audience, if you have particular 1 or 2 questions we can have, and then we can proceed for the lunch break. So if the audience is having any specific question related to this topic, we can have 1 or 2 questions. So anyone having question, please.
Thank you, Professor Wong. It was a fantastic presentation. Especially I found that it is very applied. You yourself mentioned that translation is a little difficult for various reasons, because of diversity of cancer receptor, etc. Which everyone understands. One my question is that you mentioned in your experience there is new linkages you are doing. For example, carbohydrates and C18. So, if you make new links, so that itself will become, go through a phase 1 trial, multiple toxicity. So I feel that you will have to do that itself. So can you avoid that? Because the moment, whatever is that, whether it is carnitine or any of the carbohydrate-based links are there, that will go through all tox studies and phase 1 trial. Then you let go.
Thank you. I think it's definitely very true that if we conjugate excipient A and B, they will form a new excipient and require more safety and toxicity tests before you can use it in the clinical stage. But I personally feel that there's conflicts commonly between academy and industry. So for academy, we actually tries to look for something newer and newer. And if without developing new material, then we'll be like going backwards. But for industry, of course, doing conjugations, doing covalent chemistry, will produce a new entity. And that will be very costly to test. And if it fails in the test, it's actually a waste of money. So I guess that for me, I actually take a mid-road between academy and industry. So for cancer nanomedicines, I try to apply grant and doing research by developing new materials. But I do note that I must have some contributions to the community. So I did engineering to contribute back to the community. So we built our own nano spray dryer. So I cannot tell you the existing brand. We have bought the existing brand in the market, but it takes me 2 days to produce 10 milligram. That is a little bit too low and too slow. So what we did is we built our own nano spray dryers, and within 1 to 2 hours, we may be able to collect 100 to 200 milligram nanoparticles. And for machine, it's not going to kill any patients. So this can be commercialized easily, and first in the research institution, and subsequently once it's popular, we can actually commercialize in the industry. Yeah. So it is actually a struggle between academy and industry.
Thank you.
Good afternoon, sir. Sir, how can the interdisciplinary collaboration?
Okay. The interdisciplinary means usually in my projects, I have one synthesis chemist, I have one nanomedicine designer, And the nanomedicine designer commonly is someone from pharmacy background or pharmaceutical sciences background. We need the biologists. We also have molecular biologists. And we have vet involved because we need to do the in vivo work. And for clinical study, we actually have a medical doctor from the Faculty of Medicines. To produce the nanoparticle from nanomaterials, we actually engage engineers to build our own production manufacturing equipment. So you can see that expertise from different faculty and disciplines are coming in to succeed one objective, that is cancer nanomedicine's design.
So thank you so much, Professor Yang, once again, and it's a nice presentation, very informative presentation, and thank you so much.
Thank you, sir. May I now invite Professor Dr. Shubhendu Kumar Shahu, Head of the Department of School of Health and Medical Sciences, Department of Pharmaceutical Technology, to please come up on the stage to felicitate Professor Dr. Sajal Kumar Shah. Thank you. With great respect and admiration, may I now request Professor Wong Ting Hui to accept this token of appreciation from Professor Dr. Sajal Kumar Shah. Thank you, sir. I request our dignitaries to please take their respective seats off the dais. Before we head towards the lunch, there's some announcement regarding the same. Regarding the scientific presentation information, the oral presentation will begin after the lunch at AU2, that is School of Pharmaceutical Technology and School of Allied Health Sciences, at the building of School of Health and Medical Sciences, Adamus University, ground floor. For poster presentation starting from 1 to 1:20, it will be at the Convention Center Canopy. The volunteers who have not collected the food coupons, please collect it from the registration desk. We will head towards the lunch right now. We are sharp resuming here for further sessions after 40 minutes. Exactly it's 2:05 p.m. We'll be here within 2:40 p.m. to resume back. The final announcement, the external participants, faculty members, industry personals, PhD scholars, UG students and PG students are requested to visit the left side of the food counter for your lunch. The PG and UG students of Adamus University are requested to visit the middle row of the food counter.